Let's get started. Thank you, everyone, for joining us this evening. We have a very special program tonight on efforts in health equity, working towards a more diverse and value-based medical care. I'm very excited to have these two people with us this evening who have spent their careers working to correct for the kinds of health access and outcome disparities that really have only been amplified over the past few years. So thank you for joining us, and thank you to our panelists. I first want to welcome YANA Board member and community health practitioner, Dr. Patrice Yang. You can wave and say hi. She is the Yale College class of '98, just had the 25th reunion on campus. So, which college? Sorry. Trumbull. Okay, Trumbull College. Great. Patrice started her medical career after college, really starting in community health as a Peace Corps volunteer in rural Burkina Faso in West Africa, and we're going to hear a little bit about that, before going to earn her medical and public health degrees from Emory University in Atlanta. She has had medical training in broad spectrum family medicine practice and resident teaching, and her passion for providing healthcare to underserved communities has taken her to far corners of the United States, from California to Florida, Hawaii to Alaska, and globally, not only in West Africa, but as well as India, Haiti, Nicaragua, and most recently with Médecins Sans Frontières, which is Doctors Without Borders, in the Democratic Republic of Congo. Patrice is board certified in family medicine and credentialed as an HIV specialist by the American Academy of HIV Medicine. She currently works as a primary care provider physician at Care Resource Community Health Center in South Florida. And so we'll have a lot of questions about all of that for Patrice. I'm also delighted to welcome Houston resident and clinical medical assistant professor, Dr. Stephen Starks, who is also a Pozen-Commonwealth Fund Fellow in Health Equity Leadership, and I know it's on his background, at Yale School of Management, which he should complete next year. And he's very kind because he's actually in the middle of that program and has finals like this week. So thank you, Stephen. He is also, in his day job, a founding faculty member, the chair of the Curriculum Committee's DEI Task Force, and the rising chair of the Admissions Committee at a relatively new medical school, which is the University of Houston, recently named Tilman J. Fertitta Family College of Medicine. Dr. Starks is an alumnus of the University of Houston, yay Houston, and he earned his medical degree from the Louisiana State University Health Sciences Center, not too far away in New Orleans, and completed his residency in psychiatry at Baylor College of Medicine, also in Houston, and then a clinical fellowship in geriatric psychiatry at Yale New Haven. Stephen also has an extensive background in health policy, having served as a health and aging policy fellow and the American Political Science Association Congressional Fellow. He'll tell us about that. Stephen is a diplomat of the American Board of Psychiatry and Neurology. Now, there's no way I could get every single one of their accomplishments so far, but hopefully that'll give you a little bit of taste. So I want to start with both of you, is why medicine in your particular field? What led you to where you are now, and kind of what are you focusing on now? So Patrice, let's start with you.
Oh, thank you for that really nice introduction, Rachel, and thanks for having us on this panel. Everybody, I agree with Rachel. Feel free to jot questions in the chat if you have anything specific so we can make this more valuable for you. But medicine, really I went into after, as you said, after being a Peace Corps volunteer in community health. I just saw so much medical need that I was, ill-equipped to be able to address. And it really just propelled me to this desire to obtain the skills to be able to address those needs. But I also wanted to, that environment showed me too that I did not want to replace the local healthcare, workforce and working in those communities. I wanted to be part of building capacity. So that's what sent me into medicine and into public health, and later into medical education, is just this desire to obtain this, tangible skills to be able to address some of that dire medical need. And I love what I do. I think I feel like I'm one of the luckiest people to have the job that I have. I mean, being able to play this role in people's lives is just so gratifying, to be able to help people in the way that we do, to live healthy lives, to improve their quality of health and to have ongoing relationships with them. where in situations where people are very vulnerable and there's a lot of trust that is needed in these relationships. It's just I really enjoy what I do. Of course, there's some frustrations and things with our healthcare
We're going to get into
system
that for sure.
I have, which we'll get into. But that's what led me into medicine, and I love it.
And so what was your medical, like, so what was the path? Or just after the Peace Corps, you decided I really want to go build the capacity myself to learn how to do this.
Yeah. So
and then what did you do? Like after medical school, how did you decide to go into the field you're in now?
Family medicine. Yeah. So I went into family medicine because I wanted the broadest skill set to be able to address the biggest needs. My intention was always to go back to the work in developing countries. And in that way, you know, if you have a very focused and highly specialized skill set, in the way that your other skills atrophy, then you lose the ability to take care of the most people. So I went into family medicine because I wanted the broadest skill set. And I trained in a county health system, you know, a safety net system in the Bay Area, in full spectrum family medicine. So after I finished residency, I was treating all patients from cradle to grave. You know, I was delivering babies, I was taking care of children, following my patients into the hospital. I also started teaching residents. So I went into medical education so that I could get those skills to do the capacity building, to train other healthcare workers and help to build local capacity. So that's why I went into family medicine. And soon after residency, I was drawn into HIV. I was still working in that safety net system, the county health system in Contra Costa County. And I was drawn to HIV in part because I really liked the intersection of some of the social factors that surround the transmission of HIV, and also that are needed to be able to fully engage patients in the chronic care to control and also to prevent transmission, you know, from a public health standpoint. So I really enjoyed the intersection of those, you know, kind of social factors that surround like sex, injection drug use, you know, lack of prenatal care, those kind of things. And I continued my career in medical education, teaching residents out there. I also taught residents here in Miami, as well as medical students here in Miami. And the clinic that I'm working in now actually has a practice that specializes in HIV care, but also gender affirming care. And I have found the same set of circumstances have really drawn me into that work as well. Just in terms of the need that is there, the healthcare need, it is truly an underserved group of people. And within the medical profession too, I think that we have a lack of, you know, providers, and the representation is not always there to be able to offer compassionate and, you know, high quality care to these patients. But I'll save some more.
No, yeah, we're going to definitely talk about the kind of patient community that you both are looking to serve, as well as the institutions from which you're serving. Before we do that, I don't want to skip the fact, because we may not get back to it. You didn't just go from your residency and teaching right to where you do. I mean, I just listed all these countries. Like, how did you go to practice medicine all over the world, essentially?
Well, some of the work that I did earlier on was more relief work in nature. So like the work that I did in Haiti I worked in Haiti twice, and both of those were more kind of relief, you know, emergency, like after the earthquake that I did. And then the other work that I did abroad in India, there was a public health component to it. I was studying quality of care in reproductive health in India. They have very rigorous population policies, population control policies that impact how they promote contraception, actually. And then the work that I did in the Congo was really kind of the ultimate experience in capacity building in developing countries. And we worked alongside with Ministry of Health personnel in a long-standing project. Actually, it was not a relief project. It started out as a relief project from because it's a conflict zone. I was in Eastern Congo. And then it stayed because as the conflict persisted over time, all the other aid organizations kind of pulled out towards the end. It was only MSF. And so MSF, though they're not classically seen as a development organization, they do have certain projects which have more of a development feel in that, kind of capacity way. So we supplied the equipment and medications and supply, and then my role and the other expats' roles were to kind of work alongside the local healthcare workers to help train and supervise the care that was provided. So I got to work with a lot of midwives, nurses, community health workers, did a lot of trainings, a lot of public health work, as well as hands-on clinical work. It was really amazing.
Good. Well, I mean, people may have, and we could do a whole other program on doing medical care abroad and things like that, but I want to get to Stephen. And this idea of like global relief and catastrophe stuff just brings me to maybe the very beginning of your story of why and what happened when why did you go to medicine, and then kind of what happened just as you started training in medical school?
Yeah, this is great. And Patrice can tell you we have to write a lot of personal statements for every step of our professional journeys as it comes in. And so sometimes when I retell this story, I want to make sure I'm accurate and can speak from that experience. But I think the initial formation for me was just a curiosity about the brain and behavior, right? So I think, always kind of pretty proficient in math and sciences. And my mother was a school social worker in the New Orleans public school systems. And you can imagine that in the late 70s, early 80s, and into the 90s, New Orleans had a lot of issues in terms of community violence, gun-related violence. Unfortunately, we're still having the same conversations about that. And also dealing with children at times who were dealing with emotional distress and emotional disturbances. And so for me, as her son, as she shared that story with me, she'd always kind of point out the privileges that I had in terms of, coming from an, quote unquote, intact family, 2-parent household. And so it was always curious for me how people who live in similar or close confines in terms of communities go along these different paths and trajectories, and sometimes tend to fall off. So I think that was the initial curiosity. I knew about, child and adolescent psychiatrist, and knew, at least for me as a teenager, that I wanted to be a brain doctor. I didn't know if that was going to be neurology, psychiatry, or neurosurgery, but I know that was fascinating to me to think that, this organ kind of contains everything that regulates our emotions, behaviors, and mental state. So that was the initial kind of curiosity. And in my undergraduate career, I wasn't incredibly focused. And so sometimes kind of wondered if I was still going to head on that path. It wasn't until after I graduated and started actually my volunteer work. So started working in a large health system here, Memorial Hermann Hospital here locally in Houston. Started to work at the Healthcare for the Homeless Houston system here, and started to really kind of engage in, patient care, again, obviously from a distance, being a volunteer, but something about it fascinated me. So people coming into these health settings, feeling, at times vulnerable, going through these, challenges in their life, and here these institutions were helping to be a part of solving the problems that patients, families, communities face. So that was my kind of initial introduction and path. And I think with any of these things, right, and Patrice, you can speak to it as well, when you're starting to kind of formulate your ideas about it, you never know if it's quite going to be the right fit or the right kind of stick. But ultimately, I did, once I matriculated into medical school, was just very kind of curious about what the next step or stage would be. And what you alluded to, Rachel, was the event that happened at
alert.
medical education. So 3 weeks into I just moved from Houston to New Orleans in July, started medical school in New Orleans in August of 2005. And then 3 weeks into my medical education was Hurricane Katrina, right? So hard pause, hard stop. I was living in New Orleans East at the time. My house and community was flooded, personal losses of family members as a result of the hurricane, but also subsequently thereafter. A lot of times we don't always have conversations about the people who died probably within the 12 to 18 months after the hurricane. Again, significant kind of mass trauma for a community to try to overcome. And in addition to the very kind of political environment and the economic challenges that many communities of color tend to face. I think a lot of people probably on this conference had understood or at least learned about the issues that happened in the lower Ninth Ward and other communities within the New Orleans metropolitan area that were historically disenfranchised. So for me, while I didn't consider it at the time, because you're personally in it and trying to kind of overcome it, I think that definitely kind of shaped my perspective on how I look at health. So it's not only about working directly with the patient, it's these other kind of social and societal factors that influence how people are able to receive adequate, high quality and consistent care. So that was the initial thought behind it. And then my path towards psychiatry, again, was a little curious, right? There's a lot of stigma, as most folks know, around mental illness. And I think there's even, stigma around choosing, at least at the time, it's a little different now, about choosing psychiatry as your chosen specialty. So oftentimes your supervising physicians or attendings in other specialties don't always support it. So they always, look at it as maybe a pseudoscience or just not, what a quote unquote real doctor would do. And you also, at least for me personally, had to face the challenges of my family, right? Who wanted me to be that plastic surgeon or something that might have something that they could benefit from, or something, again, that might have, a higher level of status. And so for me, I entered medical school saying that I was going to rule out psychiatry. I wasn't going to do it, but I wanted to learn everything I could about mental health and kind of addressing the needs of patients with mental illness. And for me, that actually led to my connection to the American Psychiatric Association, which is the oldest medical society in our country since 1844, and a place for me that I think has been as important for my own personal and professional development as my education and training that you mentioned. And so for me, I was exposed to psychiatrists, not only working and interacting with patients, but the different specialties within psychiatry. So geriatric psychiatry, addiction psychiatry, child and adolescent psychiatry, et cetera. And also exposed to an organization that not only focused on enhancing kind of professional development and practice standards, but also really kind of interacting with the community. So whether that be raising awareness about psychiatric conditions, or whether that be focused on advocacy and government relations, for me, it gave me this space to figure out, okay, there's something outside of kind of practice and direct patient care. And so, yes, chose ultimately, again, decided that the path to psychiatry was something that was meaningful for me, had some great experiences on an inpatient psychiatry unit as a medical student, actually saw patients improving. Patients would come in with their lives kind of fractured and falling apart, at least from a certain perspective and vantage point. And then I saw that the care that they received in these inpatient hospitals in moments of crisis, whether it be, psychotic symptoms, hallucinating, or very severe depression or suicidal thoughts, they seemed to kind of recover with time. And so I kind of liked that immediate experience. And I also liked, we talk about the types of tools that we use in practice. We have the stethoscope that we can kind of listen to heart sounds, to lung sounds with. But I felt as a psychiatrist, you were kind of the vehicle. You had to be observant, and you had to listen and really kind of interact with the patient. And you were kind of directly a part of their healing, which I connected with. And so I did my psychiatry training at Baylor. And then my path, again, I think toward geriatric psychiatry was sort of in line with what my focus was in psychiatry. So looking at patients who have been made vulnerable by societal factors, patients who are oftentimes overlooked. For me, even within a group of patients with psychiatric conditions, older adults were often overlooked and discarded, and again, observed the same challenges that I did in terms of stigma about that choice. So also in the house of psychiatry, working in geriatric psychiatry is something that sometimes I think folks didn't look at as, again, something that could be therapeutic, because I think the association is always with cognitive issues or dementia. And so how can you really engage with someone from a psychodynamic perspective if they don't have the cognitive reserve to really kind of participate in it? But I've really enjoyed that transition because I think it taught me more about systems of care. So I've been able to see and treat patients in home-based settings, so being a doctor who does house calls, to working with patients in geriatric residential care settings like nursing facilities and assisted living facilities. And so observing patients in those different settings, at least for me, and I'll stop here, got me to think a little bit more about more problem solving. So identifying gaps in patients, older adults' access to care, and thinking about what is the part that I can play in that. And so that helped me to transition from practice and the choice of psychiatry to thinking more broadly about policy and also about aspects of healthcare management.
Okay, good. I think we're gonna definitely. Well, I want to talk a little bit more of the organizations where you are, both of you are, and then kind of the patients that you're serving, and then we can get into some of these larger issues about how to address what's going on with the medical care in our system, based from the structural medical training, and then the actual practice, and then weaving in some other policy issues. So let's start. So Patrice, tell us a little bit about. I mean, maybe people know, maybe not. People don't know. What is care? You made references to safety net systems. I mean, we've heard that certainly just general political discussions about safety nets, which for maybe the average citizen might mean anything from Social Security to food stamps to medical care. What does that mean specifically in the medical care system? And then what is, what are you doing? What is Care Resource? And I know you said it was I've learned a federally qualified grant-funded health center. What is that? How is it funded? What does it do? So tell us a little bit about kind of the organizational institutions through which you're now providing medical care.
Yeah, I think safety net refers to like county health systems, the federally qualified health centers, the community-based health centers, free clinics, refugee care, migrant health centers, homeless health clinics, and generally, and even health centers for residents of public housing. It's generally is meant to be the safety net for those who don't have the resources and the access to more traditional, private healthcare services. So usually there is outside funding, government funding associated with this. It doesn't always mean that people are uninsured, but oftentimes it's uninsured people. And federally qualified health centers in particular, most often are community health centers, meaning that we provide primary care services in underserved areas. So underserved meaning socioeconomically, and sometimes there are certain communities where there just aren't very many healthcare facilities or healthcare providers available in that community. Federally qualified health centers also have other rules that they have to follow in order to qualify for that federal funding, meaning that we see patients regardless of the ability to pay. So the majority of, I would say over half of my patients are uninsured. The remainder are what I call underinsured. So oftentimes Medicaid and Medicare, they may have, and even affordable healthcare plans for some patients are underinsured, meaning they can't get the access to the providers that they need, or their deductible so high they just can't afford, a screening colonoscopy or something like that. So we provide care for patients regardless of their ability to pay. There's a sliding scale involved, like the majority of our patients can be seen for $10, and we do blood work and labs and things, so we give access to care in that way. We were federally qualified health centers were important vehicles for distributing in the early days of the pandemic tests and vaccines when they became available. So we are that safety net.
For many people.
Yeah.
I don't remember if we talked about this before, or whether at the top of your head, what percentage do you, and Stephen, from a policy perspective and kind of understanding the legislative process, what percentage of the Americans in our country receive their medical care through these kind of safety net or healthcare, federal, funded healthcare centers? Do you know, like roughly?
I'd had to look that up. I don't actually know.
Well, we can get that data, but
Yeah, it's a pretty significant number. I don't know off of the top of my
Yeah,
head either. The Health Resources and Services Administration is what where the funding mechanisms for the community health centers, FQHCs, come from. And I do know that just in terms of the breakdown, as Patrice mentioned, it does tend to see have a higher or disproportionate amount of folks from racialized and minoritized groups who do receive their care and services based on the economic inequality that Patrice talked about.
And they're all over the country? Are they evenly distributed? They're highly concentrated in urban set? Is it by population, or is it by how the states allocate where centers are going to be? How are they actually sort of determine where they're set up, I should say? Stephen, maybe from policy, do you know? And then Patrice, from what you know. Stephen, do you know?
I actually do not know.
Okay.
So I know, at least here in Texas, there is a large gap because many of our counties actually don't have access to those. But yes, that's a good question. I don't know specifically.
I'm sure we could get the data if we really wanted to do it. And that's my fault for not pulling ahead. Patrice, do you know? I mean, I'm having looked a little bit into this. We could get the data, just a background kind of question, but we're getting a better sense of the communities. So, so you're providing, so underinsured, people who don't have other places to go, and then some of the specialties you've been talking about, Patrice, HIV, other sort of effects of socially determined factors. And Stephen, that's kind of what your initial curiosity and interest in providing healthcare, but now you're doing it on the kind of institutional training side, and maybe even on the association side. Again, as you say, through the American Psychiatry Association, some of these other professional organizations thinking about the training and the business and the operations of medicine. So tell us a little bit about this new medical school. What's it all about? Why are you there? And kind of what's the goal?
Yeah, it's a great question. So for me, so the connection for me was I learned about the opportunity actually when I was still on the Hill as a congressional fellow and trying to figure out what the next step was going to be. At the time, I thought I would pivot a little bit and work for a large medical association, work for a think tank, but then the opportunity presented itself to be at this new University of Houston College of Medicine, renamed, as you mentioned, since that time. And that was exciting for me. So I thought back to myself about the faculty members who really nurtured my interest in medical school and how important that was for me. I thought a little bit about the curriculum that I received at the time that didn't always fit. I was at a very traditional medical school. And so that means in the first 2 years, it's just mostly kind of your basic, your biomedical sciences in your first 2 years. And then you transition in your last 2 years to working in clinical environments on your rotations as clerkships. But I felt that there were some gaps in my, I thought there were some missing gaps. So I didn't get a lot of kind of culturally informed information, or didn't get information about, kind of social determinants of health in my undergraduate medical education career at the time. And here was this brand new medical school, right? In a place that I'd called home for a significant number of years. And their focus and intention was on all the things that I was interested in. So increasing diverse representation in medicine, focused on community engagement, and specifically kind of addressing the concerns of two historically excluded communities in Houston's 3rd Ward, which is predominantly African-American community, and Houston's East End, which is a predominantly Hispanic Latinx community. They were also focused on addressing health disparities. So all of those things really started to kind of pique my interest and led to my decision to return home. And I also appreciated the impact of being in a university, right? We all know about kind of great educational experiences in higher ed. And so the opportunity, given the impact that the university has on the larger greater Houston area, really attracted me to it. And also the fact that it was this interprofessional environment. So we have our College of Pharmacy here, we have our Law Center here, we have our College of Nursing, our Graduate College of Social Work. And so being a part of that environment, I thought, okay, I can help something to grow here, and being able to, again, really kind of directly impact and mentor the next generation of Texas physicians. The other focus of our college is to graduate our students into primary care specialties. So we all know the importance of great primary care. Unfortunately, not enough people know the importance of great primary care. Patrice, I'm sure, can talk about her own direct experience, but we don't have enough of that. We already know that our primary care physicians are oftentimes overlooked in the healthcare landscape, and definitely kind of underpaid, undercompensated for the increasingly more difficult work that they have to do, right? Like everything that they hold in. So really preparing students to work in those environments and to prepare students to work and serve in underserved and historically under-resourced communities. So whether that's urban areas, whether that's kind of communities of color, or whether that's some of the rural parts of our state, to kind of address needs and gaps in care, really kind of attracted me to it. And since I've been on faculty, I've just been very inspired, one, by our students who are phenomenal and fantastic. We started off our first 2 years with 30 students, and we've enrolled our third class. We're doubling to 60 students this year. They'll start their orientation this July, but it's been interesting for me. I've worked a little bit with resident training, so postgraduate medical education. This has been my first foray into undergraduate medical education, and it's been so meaningful to be able to shape curriculum in a way that gives our students advantages. It's also been, I think, important for me also to be a part of the admissions process and recognizing the importance of being a gatekeeper of sorts, or recognizing, historically who had access to medical education. And we had talked a little bit more in our previous conversation about the very kind of poor numbers when it comes to
yeah, because you're not just developing curriculum and working it, you're actually taking a concerted effort to change who goes into medicine, not only what they're doing on the other side. I mean, before you told me, what was your own personal experience when each of you was in medical school? How many years ago? We now 20? 15 maybe?
Yeah.
What was it like? And then I know, Stephen, you actually have some data at your fingertips about the kind of diversity demographics, but I know, Patrice, you were in Atlanta, right? It's a big southern city, in Emory. Do you recall, like, what was your, thank you for pulling up that data. What was your, just while we're on it, what was the student body and the faculty body like who was training you when you were in medical school?
Oh man, so that's interesting that you asked that. I found out at my reunion this weekend, which I never realized, but my class at Yale apparently was the blackest class of all. Like, we were known, class of 97 was known for that. I didn't know that was, I thought all of the classes represented as ours was. But in medical school, when I interviewed at Emory, one of the things that really attracted me to their program was they had a new director of admissions, and the class above mine, so the ones that were doing all the hosting and recruiting for the people we're interviewing, were 20% underrepresented minorities. And I just thought, so this was back in 2000, I thought that was, or 2001, I thought that was amazing, and fantastic. And that really, I thought that was, very progressive, especially with Emory being in the South. I grew up in a economically depressed area of Southeast Arkansas, so I'm very familiar with the norms in the South. I thought that was amazing. That really was one thing that drew me there. However, when my class entered, somehow we were 5% underrepresented minority, which to me felt like a bait and switch. Of course, admissions are kind of, tricky, who you accept and who actually ends up matriculating.
Stephen can talk to us about that a little bit.
Yeah.
And what about the staff? What about like the medical
staff? I felt was
faculty
was not diverse at all, and I felt my classmates in my particular class was not very diverse, and the faculty that I had were not very diverse, and I felt oddly transported back to my kind of upbringing in what I described for you, economically depressed Southeast Arkansas. I felt that even though Atlanta is a big city, a big metropolis, but the feeling that I had at Emory at that time, at the medical school specifically. I think the undergraduate, was more diverse than my medical school class, but I didn't feel that it was very diverse.
Interesting. Now, Stephen, what about when you started, and then tell me what the data says, and then what University of Houston Medical School is doing now? So.
Yeah. So when I started, entering class 2005, class of probably 185 or so, 88 students. There were only 13 African-American students in our class. And I say that because, again, if you think about the demographics of New Orleans metropolitan area, especially then, right, we're talking about 70%. So, and there were a lot of efforts, at least from our Office of Minority Affairs at the time, to really work on kind of diversifying the workforce. And historically, there had been issues. There was a large consent decree, Department of Justice kind of designating many medical schools in the South, and not just in the South. It was a larger problem in terms of increasing diverse representation in medicine at the time. At the time, I don't realize that again, I knew it was low numbers, but again, we kind of built a sense of community there. And then overall, in terms of medicine, so we do know specifically for those groups who are termed or designated underrepresented in medicine, and that includes African Americans, Hispanic, Latinx communities, mainland Puerto Ricans, and then indigenous populations, so American Indian, Alaska Native, Native Hawaiian. It's still less in total than 10% of all matriculants in medical school. And the numbers may have adjusted a little bit, but that just gives you an idea as we kind of compare that to the national demography. And so there has been a large call, and I'm actually also a part of the Association for American Medical Colleges Action Collaborative for Black Men in Medicine. There were particularly kind of dismal numbers reviewing the data from 1974 to 2014 to show that during that 40-year span, the number of Black men in medicine actually dropped, right? And you can think about the enrollment increasing during that time as well, a number of different factors. So very desperate numbers there. And that's something I think many schools have been working on in the midst of everything that we're working on in terms of addressing social justice issues since 2020. Still have a very long way to go. But to your point, that was one of the reasons that attracted me to the university, because they were very intentional about kind of recognizing that and addressing that gap. And in our class, we have now 75% in terms of our total enrollment who are underrepresented in medicine. And so it was very nice to be able to see those two classes. It actually, our image of our first class went viral because it finally kind of reflected the local community there. But to that point, right, it was 2020 when that occurred. And so we're still a long ways off, still have a way to go, but this is one important way of kind of addressing some of the gaps that we know. And Patrice talked earlier about, vaccination rates and vaccine hesitancy, or what some people term vaccine inquisitiveness, that many communities of colors help. We do know that when there are those kind of racial matches with patients and healthcare professional with physician, that patients tend to do better. And there could be a number of different factors tied to that. We know that, sometimes those physicians listen more or longer, or they document more intently, or again, it's, part of their lived experience. When, you or your family members have faced, racial discrimination and receiving care, you're much more sensitive to the needs of those communities there. And so we know it's incredibly important to, representation does matter, leadership does matter as well. And so I've been trying to think about ways to integrate both of those ideas and to ensure that, our medical colleges and other, places are held accountable to addressing these gaps when it comes to diverse representation in our physician workforce and our mental health workforce.
Got it. And that's a really interesting kind of segue. I want to kind of turn to these sort of, barriers or major factors in our inability in our country that maybe we're getting there to really provide the kind of care that's going to meet the needs of the people who are most vulnerable and really need it. Diversifying those who are providing the care is one way. And I know it sounds like, at least with the University of Houston Medical Centers, maybe, and I hoping that there are other ones out there. And I don't know if you know of them, but maybe even through your professional association, we're learning of more. And it's not just oh, we'll make sure, it's just affirmative action. There's actually a little bit more concerted thinking about the communities you're serving. One thing, and each of you has alluded to this a little bit, maybe you could each talk about this, about the kind of the pressure of specialties versus general care, and what the curriculum in medical school is like, and kind of how that, whether it's, it's bias, it's, you can talk about student debt, just basically why in our country we're set up with all these specialties, just in the kind of training and in the actual field practice. So, Patrice, if you want to, like, why is it so hard? Like, why don't we have enough doctors who are providing general care? I don't know, Patrice, go ahead.
It's a really good question. I mean, so just, it's a good, you asked before, like what we can do. And I definitely think the work that Stephen is doing to build more inclusive workforce is part of what we can do to address health equities. But another thing that is problematic in the US healthcare system is that we do have an emphasis on specialty care. We do compensate based on the number of visits as opposed to the quality of care that is being provided. That's why when you go to the doctor, you wait for 2 hours and then you have 10 minutes and they're typing in the computer the whole time. It's because of our healthcare system, and it is unique, I feel, compared to other healthcare systems that I'm aware of. Even in Western Europe, the percentage, the breakdown of specialists versus primary care providers is more like 70-30, 70% primary care and 30% specialists. In the US, it's the opposite. It's about, 2/3, 1/3. It's 2/3 specialists and maybe 1/3 primary care. Primary care being family medicine, general internal medicine, and general peds. And there are a lot of factors that go into why medical students, choose to go into specialty care as opposed to primary care. And part of it is, compensation. And that comes from, in our current healthcare system, that comes from what the payers are, the insurance companies, are the third-party payers, what the payers are compensating and what they're valuing. So, and also the burden of care that is placed on individual providers. So all of the, measures and healthcare that is asked of, that is important for quality primary healthcare is not necessarily reimbursed. And so what you have is a really heavy workload, and primary care specialists are among the lowest paid of the specialists. I mean, you could have the average, I think that the median there was a Medscape does these surveys of physicians. And so it's not comprehensive, but it is widely cited because it's data that we have on income. And I think that it's, an orthopedic surgeon or a dermatologist or a plastic surgeon, earns 3 times as much as a primary care physician or even an interventional cardiologist, right? So the choice that you make coming out of medical school, I have co-residents from, my family medicine residency that graduated from residency with $500,000 in debt. And who comes out of, and during residency, I mean, most professional schools, you come out earning your full salary. As medical students, you go into residency and you're paid, I mean, when I was a resident, it was $40,000, for 3 years. That was the salary. So you've got this enormous debt. You're not paid well off the bat. And by the time you come out of residency, you're at the stage of life where you want to buy a house. You expect to be able to buy a car. You expect to, have a quality of life after all these years of grueling work. And so I think a lot of people choose to go into specialty care because 1, it pays better. And 2, in some ways, I think it is less of a headache, so to speak, because you're very focused on this one area, this one, organ system. If you're a dermatologist, you care about the skin, and everything else is like, oh, talk to your PCP about that. Whereas in primary care, we really are more focused on holistic care, on the whole picture, which obviously is much more complex care. And there's a lot more in primary care and engaging people in the plan, there's a lot more required in terms of people skills, meeting people where they're at, and being able to build that trust and being able to spend the time to explain that and allow the patient to participate in what the management plan is. It takes time. It takes a conversation to explain, this is why you have this condition. This is what we can do about it. These are your choices. This is what you can expect in terms of side effects or monitoring or, you know, long-term outcomes if we don't treat this. It takes time to explain those things, but that's not what the payers, the insurance companies, reimburse. So primary care in the US is really difficult. It's very, I think a lot of people just don't want to be, they don't want to be tasked with that enormous burden of work and be given, and not be given the tools or the compensation to do that level of work. That's why we have so much burnout in primary care.
Right.
I mean, we're trying to take care of, I'm trying to address, I mean, have you ever been to your doctor, right? And you say, oh, would you mind, you know, I'm also, you know, would you mind refilling this medicine? Oh, only one thing per visit. And you're like, I just took half a day off from work for my one, you know, 10 minutes with you. And now you're not going to do these other things. That's not how we're trained to practice. That's not providing good care, but that is what the system imposes upon us.
So let's talk to Stephen, who's trying to work that system. Now, I know the University of Houston, they're doing a couple things, right? Not only diversifying stuff, and may not necessarily be the first. I understand there are some other maybe and I'm looking just generally at some of the other medical schools, like there seems to be a little bit more of primary care based. I don't know if it's this, I don't know how it works for training in medical schools, but what is the University of Houston doing, like, and why and how does that make it different? And then also about like the costs and placements and all that kind of stuff. What are you guys looking at?
So to your point, in addition to everything kind of Patrice discussed, it also made me think about, and Patrice, you can think about your experiences. I was thinking back to mine. I think a lot of your clinical experiences, so when you are working as a student being exposed in your clerkships, a lot of it's hospital based. And so you really, you know, I don't remember what the percentage was, but most of it's kind of in that setting. So one, it's a lack of exposure, perhaps, to primary care. And even when you are exposed, Patrice talked about, you know, the frustrations patients feel, you know, the professionals sometimes feel frustrated and feel handcuffed with the limited amount of time that they have to spend with patients, that even those experiences might not be positive for students because, you know, they see the stress and duress that some primary care physicians feel in their practice. And so that's, you know, in terms of like modeling, that doesn't look very attractive or as, you know, quote unquote sexy as some of the other experiences might be. Patrice, would you say that? I don't know if you work with students.
Actually, I think you make a really good point that I omitted, but it's true. In medical schools, there's usually academic centers, right? And so who you get exposed to is the highly specialized, the tertiary, quaternary, you know, specialty healthcare systems. And so you don't necessarily get the exposure to the community providers, people who are working in their private practice. You get exposed to the academics and the people who are in specialized settings. So I think the exposure is part of it. And there are some schools though that are working on that and placing students in communities for their training.
And we're one of those, yeah. So we actually start our students off in their first week of their medical education in a longitudinal primary care experience. So one half day they're in clinic, so they kind of have that exposure. And to your point about the financial incentive too, at least for our first class and even our subsequent classes, we had an anonymous donor for our first class. So all of those students had, virtually kind of free tuition, and that really changes the trajectory on things. It makes it maybe easier to make that choice into primary care. Again, still underpaid primary care or family practice specifically and pediatrics, but we definitely can kind of do better and hopefully kind of move to more value-based models. And there are other models like the direct primary care where physicians do have more time. It's kind of a different type of payment model and structure, but there are things out of there. And so that's what we've been trying to do, give students early exposure, not only to primary care settings, but also to kind of teach them about the other factors that coincide with patients' care. So having them focused on on trying to address, or at least thinking about or conceptualizing ways they can address the social, political determinants and drivers of health. So if your patient does have, if there's food insecurity, there are food deserts, how do you really address that? You're trying to talk to your patients about great nutrition. Have you been to their grocery store if they have one easily accessible to them? Or do you understand their transportation needs and why it's so difficult for them to get to the appointments? Or if a patient's not adherent to a medication and being a little inconsistent, we might need to dive deeper in terms of asking them questions to kind of garner what their challenges are. So is it a problem with affordability and you didn't really think through the right blood pressure medication and offer one that they could take? So I think that's how we're at least trying to shift the focus a little bit in our kind of core curriculum and advanced curriculum.
That's amazing. And I want let's dive a little deeper into this. This is sort of like, we've talked about, the diversity in the workforce, maybe the specialties, the pressure of the insurance payer system. And the other big one is sort of really understanding the social determinants of health. Now, when I sort of looked at this from a sociology standpoint, maybe 8 years ago, it didn't seem like that was trickling through to the medical training and stuff. Has that changed over time? And when you guys were in medical school, did you have grand rounds and training and lectures and things about, I don't think the whole concept of social determinants of health and understand how it actually affects biologically and epigenetically that's relatively new, I would think, from a medical research standpoint. And then how do you work that in from a social standpoint to really understand? So I don't know, what was it like when you were in medical school? And do you know that that's getting taught in medical schools other than these very concerted efforts at some of these, I don't know, Patrice, did you get anything?
I remember one lecture, and it was one lecture on social determinants of health when I was in medical school. Emory at that time had a very conventional standard, traditional curriculum. But when one of the medical schools that I, what used to be faculty at Florida International University here in Miami, developed a curriculum on teaching students social determinants of health starting from the first year of medical school. And so I do think there's definitely much more awareness in medical training now than there was when Stephen and I were in medical school. But I do want to, just tying those 2 points together, the primary care and the social determinants of health, the pipeline for the pipeline for primary care providers definitely is going to be more and more squeezed. It's going to be more and more of an issue in terms of the number of primary care providers who are available as we progress through time, because you have a workforce that is retiring, that is largely retiring, and you have people the pipeline that is coming in more and more going into specialty care as opposed to primary care. And then you have people living longer, healthier lives. So you have the geriatric, population is also expanding. So people in general, I'm not underserved, but I waited 2 months to get in with my new PCP, who I just saw 2 weeks ago. That's not very easy access. So I'm somebody who doesn't have those barriers, and I even have that problem with access. The people who have barriers because of their social determinants are going to be even more severely affected by the lack of access, the lack of the primary care pipeline. So it is really important that we talk about this, that we start addressing it, and that we start incorporating it into care models and even compensation models. I keep going back to compensation mainly because so much of that drives behavior, right? We might learn how to practice medicine in a certain way that is evidence-based, but if the payers are not reimbursing it, you do what the payers are reimbursing, because the patient's not going to want to get stuck with a bill for something that their insurance didn't pay for, So I keep going back to the payers because I also think that is where we can, advocate for reform.
We're definitely because we're going to probably just finish on the sort of what are some models of intervention, what's working, what can we do? But Stephen, last thing about social determinants of health, from understanding, having a broader understanding of what contributes to the medical problems that might come before a doctor in a clinic or a setting. How are people trained? Do we need to be bringing in more? Are you bringing social workers? Are you bringing sociologists? All that kind of stuff. You say, they're already pressured from Patrice's standpoint from just addressing what's in front of them. And what about preventive care or thinking about these sort of frontline workers. I understand that maybe from the pediatrics professional associations, there's a little bit more to understand, but asking some of these holistic questions about food security. I mean, like, how is that all taken? How are these social determinants not only in the ability to get access care, but in the way that medical care is delivered? Stephen, you want to talk about that a little bit?
It's changed a little bit in some spaces, and at least I feel like I think the community health centers may do. So when you go in to see your doctor nowadays, you may do some type of outcome measure. So some screening too, maybe a depression screen of some sort. I know some institutions, some health systems are doing the same way for social determinants of health. So a screening too to help identify patients who may be at risk. And I think the challenge though is that many health and hospital systems don't necessarily have the mechanisms to address it, right? So you mentioned it, right? Social workers have been doing this since day one. We do know, at least, not to your point about prevention, but we do at least know for patients with chronic illnesses that care management, case management can kind of be an effective strategy, right? To have someone work with them directly to kind of help them to kind of connect with the type of care that they need. But I think there is still a challenge. It is new, and there aren't an incredible amount of subject matter experts out there. There are organizations who are trying to be intentional and do it well. I know Kaiser has some, Kaiser Permanente system has some great kind of initiatives targeted toward that. But I think more expansive, and particularly for those who need it. So we didn't talk much about, and I know our time is running out, but we didn't talk about the states, the 12 states who still haven't expanded Medicare, right? I mean, in southern states, I'm in one of those. And so the challenges that I face here are much different than the challenges that my colleagues in California or in Massachusetts kind of face in terms of delivering care to their patients or in terms of addressing social determinants of health. So I think folks we're still learning and evolving with that. To your point about what's happening in terms of education. So yes, our school is trying to do it. There's some people, some in the academy who feel like we should focus on just medical acumen and leave the social drivers to other people. There are those discussions that still are happening at certain institutions. So again, I think it'll be a while before we truly address it effectively. I know at least some of our students have expressed that we teach them about these social political drivers, but they don't really have anything that they can do about it. So they sometimes feel a little frustrated with it. And we're not trying to give them, and again, our students are so eager, they want to know everything now. And sometimes that comes with time. But to their point, sometimes it's true. If you're not in the right health or hospital system, you are quite kind of constrained in terms of resources and what you can really do to address those things. So being politically active or being focused on advocacy, I think, has been an outlet for many folks in that area.
Yeah, so let's talk before we open up to questions from the audience. So what are some things that are some innovations in way, obviously, University of Houston, these kind of medical training models, but what are some other components that might help some of these disparities in providing the right kind of care in the breadth and in the places? And then what could members of the audience, if you're not in the medical field, what are some of the levers and pressure points to help change some of this stuff so, we can start to close these gaps and get everybody the care they're supposed to get? I don't know, Patrice, you want to start? You're right on the ground dealing with a lot of this. What are some of your, I don't know, it's everything. You'd mentioned one's telehealth being one. I
have found, I think that medicine has forever changed. The world is forever changed by the pandemic, but definitely the fact that Medicaid and Medicare were paying for, they kind of set the trend, right? We're paying for telehealth during the pandemic and continue to, as long as we are, have extended the emergency state. That has expanded care significantly for a lot of my patients, just in terms of, like I had described before when we were talking, my patients who are wage earners, right? If you get paid hourly and you have to and you don't have a car, you live in a place like South Florida that doesn't have great public transportation, you might take 3 buses to get to my clinic. We're never running on time because 15 minutes is never enough for each patient. So we get, a traffic jam of people being late. So Oh, I lost my train of thought.
Oh,
Sorry.
it's just about access to.
Oh, right, the telehealth. And so I
telehealth.
definitely have patients who have benefited tremendously from the telehealth, who can go outside, you know, or into a closet for 15 minutes to have a visit with me so that we can carry the plan forward, you know, and kind of alternate maybe a visit in the clinic face to face when we're doing physical exam and could check vitals and everything. And then another visit in between to carry the plan out, you know, by telehealth has been tremendously helpful. And we know that too, particularly for rural areas, that is especially helpful, telehealth and access to specialty care in rural areas where you might be several hours drive from a specialist, that the telehealth is very helpful in that way. So I think that is a big, if we can advocate for payers to continue to reimburse that, the minute payers stop reimbursing, the providers are not going to be able to do it anymore. Right. And so as long as we can advocate for that to continue, I think that will help.
Okay. Stephen, a little bit from the kind of, you've been on the Hill, and as doctors, you're also involved in the Medical Association, which I assume are also useful lobbyists down with competing with insurance, things like that. What are some other things that can help that affect some change, and what can normal citizens do to help?
Yeah, I think the first is always awareness, right? And so for some federally qualified health centers, Fqhcs may be a new, a term or something that you weren't aware of. So I'd first kind of figure out what's happening local. One thing I did learn about being on the Hill is that all politics is local. If you want a federal fix, that's going to be slow and incremental and may never happen. It took an incredible long time again for the Affordable Care Act to happen. When I was on the Hill, we were working on prescription drug pricing legislation, which seems like something everybody can agree to, that drug prices for certain specialty drugs are incredibly high, and the lack of affordability for things like insulin. But again, that's at least by the time when I was there, that was a 16-year-old conversation, and that bill, while it passed the House, didn't go anywhere. So again, politics is local, so think locally. So one, awareness about Fqhcs. If you just Google your city, town, and Fqhc, you might be surprised to find that there are places, these safety net kind of clinics that are meeting the need that you didn't know about or identify. And so if you do have a family, friend, loved one who doesn't have insurance but needs care, and you know they need care, get them connected with it. So one, figuring out what's happening locally. And I like to also start at my local institutions. And so to your point, I'm at a undergraduate medical institution at a medical college, and also am very involved in the American Psychiatric Association. So use those levers to think about ways that you can advocate or kind of amplify the message about gaps in care in your neck of the woods. I'd also say that it's important to, third point, just had it.
Leverages, policy.
Yes, policy. Thank you. So yes, your state representatives, find out who they are and have engaging conversations. If you when your legislative sessions are occurring, definitely kind of try to. Again, you don't have to be an expert, but just talk to them about what's happening in terms of healthcare policies or initiatives at the state and local level. So I think those are easy way to engage. And then last but not least, again, since many might be involved in nonprofits who are addressing community needs. So think about the community-based organizations who are filling the gap. So who are addressing food, housing, economic insecurities. Partner with them in some way if you have the time and capacity, or at least be knowledgeable about that local network and that coalition who might be working on those areas. So
massive issues you guys are doing. You're covering a lot, and you're doing very focused, working with individual students and patients, and that's amazing. And I want to thank you. We didn't even get into, there's so much we could be talking, this go on for days, have a whole conference on it. But Stephen, the other way I assume you guys have talked about, one was awareness and education. Even in maybe getting more people to be able to fundraise and donate and to medical schools, or I don't know how many historically black colleges and universities have medical schools, to diversify and help cover. We can cover the cost of medical education, maybe put some pressure to get some student loan debt and service pay, helps people so they don't have to worry about getting student debt, and they can afford to go into something like care. I know we haven't even talked about this, but floating something like a medical domestic Peace Corps, lawyers should do it. A lot of, probably every American should do it.
We do have that actually.
Yeah?
Yeah, it's a where you can get loan repayment for going to a designated underserved area.
National Health Service
Okay.
Corps. Yeah.
Yeah.
National Medical Service Corps.
Yeah.
Maybe we need more people doing it for longer and
I definitely think
permanently.
we need to emphasize, yeah, we do need to emphasize primary care. I mean, the United States spends like 17% of its GDP on healthcare, and we don't get very effective, efficient care, cost-effective care because we don't emphasize primary and preventive care. So the more we can emphasize primary care in, our policies and our payment models, I think will help overall, will help everybody, not just the underserved. It will help our general population in the US.
Well, we really just hit the tip of the iceberg, and I'm so thankful. And I hope that our audience, whether you're watching live or listening at a later time, have learned something and maybe increasing something you can take back to your communities and support the work that both of these amazing Yale-connected doctors are doing. So Patrice, Stephen, thank you for sharing your stories. I hope we can have conversations again and continue down, and maybe have a whole conference on some of this stuff, or maybe, or invite us to some grand rounds at your hospital so we can sit there with some students that are learning. So thank you for providing the care that you guys do, for doing what you do. Stay in touch, and I hope we can continue to learn and support the work that you do. So best of luck, and go get some rest, and good luck in your finalist exams, Stephen.
Thank you. So appreciate the invitation.
Love having you guys.
Thank
Have a
you,
great evening,
Rachel.
everybody. Thanks, everyone.